So this has been a very good series of sessions, and we have gone from the general to the more specific, both in general cardiology and in devices and electrophysiology, to end with the patient's views on all of this. We'd like to go through each talk in turn, very briefly, really, to pick up on the various discussion points that have been raised. I'll start with Dr. Marshall's account, and basically he describes how in a very busy group of hospitals in Birmingham, covering a large area of the population, we have been overwhelmed by the whole COVID pandemic. Our timetables have been transformed. We have gone through a period of being on call continuously for 12 hours a day for 4 days and then off, and really abandoning the specialty. Several experiences have emerged, and in particular, it's of great concern that despite being able to cope with the COVID very well indeed, actually, I must say, I think this hospital, the Queen Elizabeth, has been very good at adapting to this crisis. But at the same time, we are all conscious that many patients are unattended. And Mauro, in this respect, you also alluded to the situation in Italy, where general cardiology patients, such as aortic stenotic patients and aortic dissection, and also myocardial infarctions, have not come to hospital. What's your view on that, Mauro?
That's very sad to be recognized, but indeed, in the COVID-19 related mortality, we must number a series of patients just like those that you mentioned, with acute or acutely worsened cardiac conditions that were untreated just because of the fear of the patient to come to the hospital, or the impossibility of the system to host them in a very busy, crowded hospital because of the COVID pneumonia patients. So this has to be accounted for in the mortality related to COVID, but in a different manner. It's associated to COVID infection, not due to COVID infection. One way that we should be aware for the continuing exposure to the virus is that many cardiologic patients should be in some way evaluated outside of the hospital. We must think back of the level, the amount of care that we can provide in a different location than a regular hospital outpatient clinic. We must figure out remote medicine and other models to deliver diagnosis. And here we came with Dr. Marshall to the hard topic of how to perform echocardiography for a valvular heart disease patient, or how to perform a CMR in a patient who has symptoms very likely hindering to sudden death, just like syncope. And you have to rule out sarcoidosis or hypertrophic cardiomyopathy. How can we manage appointments for this patient in a safe workflow?
That's right. I mean, specifically in the field of devices, he alluded to various points. I mean, namely, secondary prevention obviously should be addressed, and those patients should be implanted. Brady indications, I think there is little doubt that those patients need to be done. Class 3 patients for CRT, CRTP, CRTD, of course, the hospitalization rate is very high. We know confidently that we can change their mortality, their survival, and reduce hospitalization very efficiently. I think further down the line, we may have a class 1 patient with a primary prevention ICD indication. And then, of course, right down the bottom are reveal devices, other devices as well, monitoring devices, and explants, which we've abandoned for the moment. And perhaps we could touch on that in the later presentations when that is dealt with in more depth. one thing that Dr. Marshall also alluded to was that red tape has been wiped out very efficiently. It took us months to get approval from the trust to get the telemonitoring sorted out, literally months. And this is not a problem. And clinical governance also never allowed us to use telemonitoring, or we had to get the photography department, the medical illustration department, to take a photograph for us. But now patients can send their photographs, and there does not seem to be a clinical governance problem as long as it is done securely, encrypted, respecting patients. And that's your experience as well. Am I right, Mauro?
Yes, you're absolutely right. The fact is that we have a so-called schizophrenic approach of this because as in the UK, we have been running remote device monitoring for ages without that being recognized or reimbursed by the system. Then we had to move to remote patient assistance via the web. And again, this is not recognized by the system, so the level of encryption and of protection of the privacy is much lower than what we had to be familiar with the device's data. But that was the only way to manage the patient. So we jumped across a number of legal issues just because the pandemic was there. And again, this reinforces the concept that what you should be able to provide in an elective manner shouldn't be an emergency process once you have to face it. So in my view, we shall develop a so-called regulatory system that enables a truly protected patient-physician connection inside an encrypted and a protected way of communication.
I mean, one key thing which I think was very useful when we were dealing with this within our hospital is that if the information comes from the patient, if it is the patient who sends the photograph to a secure server, then there is no problem. So the difficulty here is the exchange of information back from the hospital.
Yeah.
But certainly in our hospital, that has been fine. And I think that's probably the same for many other hospitals. In terms of the future, the new normal within a hospital, we are now, we've now gone back to our own timetables, which are incredibly patchy. We feel, a lot of us, very underemployed because we cannot get operation lists, and clinics have been cancelled. Clearly, the focus should be to reduce patient visits, whatever happens. I think that in terms of the time window, I would think about 2 years. Isn't that your feeling, that people think about the next iteration from government and the next set of advice at higher levels? But I think we need to really see for our patients what is a realistic strategy. Is it 2 months? Is it a year? Is it 2 years? What's your view on that, Mauro?
I'm totally in agreement with your point. We can't plan anything which is farther than 6 months. We have to adapt and find a way right now to see the patient again and to schedule for so-called either urgent or elective procedures. We have been back to the so-called normal flow in the past month, and what is normal, of course, is different from what we used to. So the patient is seen under an outpatient clinic with a very strict way in, just to check for temperature, and if the patient has to stay for a day hospital, for instance, a nasopharyngeal test to scan for the virus. And at that point, you can, let's say, promote whatever is the diagnostics, for instance, transesophageal echocardiography. Or if you have to plan for electric cardioversion of atrial fibrillation, then it's safe to be done within the next 40 to 60 hours. So there's a process now that allows us to do. I have started interventional procedure since 6 weeks with the same protocol. The patient is seen the day before with a fast test for the virus, and then next day he's admitted to the hospital, and we do the ICD implantation, the ablation, or the PCI procedures, or the valvular procedures. That's the only way that the hospital can deal with the so-called clinical need of cardiovascular patients that anyway represent the 40% of total mortality in our country. We can't deny that we could save lives, and we have to rule out a level of risk that we can accept to protect ourselves and the patient from COVID. I just say we have to adjust the system to go side by side with the virus until the virus will disappear.
That brings us on to the second talk by Professor Ross Hunter from Bart's Hospital, again a big center, and we considered how to run clinics. Clearly, there is no way we're going to go back to traditional medicine for the foreseeable future, and there has to be a formula for seeing patients, providing advice within those constraints. He went through 3 cases which beautifully illustrated how traditional medicine and adherence to guidelines as well are altered by this. So you remember he presented the case of an 84-year-old lady with syncope who had a bifascicular block, first-degree heart block, a left anterior hemiblock, and he then proposed what we would do on the basis of guidelines and what we would do now. And I think we all agreed, but can you give me your side of things on a patient like this?
Yeah, on the patient side, of course, you would accept what is safer for you and what is most expeditious in the context where you are put. So actually, I think from a patient's viewpoint, you are very likely to trust what the physician seems more reasonable in that setting.
So you would have opted for pacemaker implantation, am I right?
Yes, sure.
Yeah. I think that's the right thing, but strictly, if we go through guidelines, you know, that may be questioned.
Yeah, we have done it for years to, let's say, strictly look at the guidelines and dig deep into the case with a lot of thoughts. Now, the most expeditious approach is the safer for everyone.
Yeah.
If done properly, with very, very low risk, definitely it's a good thing.
Absolutely, and I think in this particular patient, we don't have it in the cardiac literature, but certainly when you look into other literature, you can see that the death rate from a fall and a subsequent pneumonia, particularly now in the COVID era, is terrible.
Yeah.
So I think there is no doubt. I think we all agree on that. He presented a second case of an 81-year-old patient who had an ejection fraction of 30%, was in atrial fibrillation, and the patient was also in complete heart block in class 2. The question there was, do we implant now? Do we wait? And if so, if we implant, which device? So I don't think there was any question that this patient has to be done. So which device? I don't think there's any contention here on CRT.
Yeah.
But what is your view of a CRT-D versus CRT-P in an 81-year-old? I know that this is slightly outside COVID,
Yeah.
But what is your view there?
Now, in my view, of course, I mostly rely, and it's not because of friendship, I mostly rely on some hints that you provided in literature. That is, as far as I look at the myocardial function of the patient, I shall not forget what is the burden of scar. And if the burden of scar is negligible, mild, I have personal experience that is very good with CRTP, especially in those patients who range between 65 and 75. Now, here we have a patient who is older than 80, and there's no point I would have used the CRTP unless I have a former CMR that tells me, okay, there's a lot of scar, the patient is still a healthy patient, is still active, has a long perspective and willingness to go on, and at that point, I have implanted also some CRTDs. One thing that would be interesting, Francisco, is we have seen in the past that sometimes we rush to through the procedure, and many times we do what is reasonable to be done in a certain time frame. Now with the COVID patient, as sometimes you are really alone in the cath lab, you can also spend 1 hour more. You can also dream of, for instance, that was the case for every block, being that in another block, you can think of teeth-driven CRT. There are some ways where COVID plays tricky because you have shortage of procedure, but you can spend more time on each procedure.
And also, it's not comfortable. The gear that we have to put on in theatre with suspect COVID cases, it's an hour working hard in a difficult procedure. It's also something that we need to think about because you get tired. And the third case was a 48-year-old lady with palpitations lasting 30 minutes unattended by any other symptoms. So palpitations, normal ECG, we know that we're dealing with a low-risk situation, but obviously we'd like to know what we get from monitoring. The traditional monitoring of bringing the patients in, it's difficult. And Professor Hunter went through different strategies. He mentioned the variety of patches, the Zio patch, the body device, there's various others around, the cardiac phone app, the Apple Watch, and the FibriCheck. The FibriCheck I wasn't familiar with, but this is a check that's done on the phone. You put your finger on the light source, I think, or the camera, and you'll get, I think it's the light source, and basically you get some idea of whether your heart rate is irregular or not irregular, etc. Clearly, all of these techniques have pros and cons. Some of them are cheaper than others, and I just wonder really what you would have chosen in this context.
We have had this type of patients in the past 3 months, and I've been using an external loop recorder that works via a portable smartphone that is dedicated only to data transmission of the ECG. So you have something which is a regular loop recorder, has 3 leads, so actually you can manage artifacts quite easily, and the patient is 24 hours a day in contact with you, either by activating symptoms-triggered ECG or automatic alerts.
And which device is this, Mauro?
Is this Vita phone is provided by, well, it's not really new, it's something pretty old. It's an updated version of an external loop recorder that has both automatic and patient-triggered activity. It's reasonably cheap because, for sure, this is reusable. You can decide the time that you want to monitor a patient and then reuse it for the next. For us, the challenge was, what if the patient becomes infected or becomes suspected? You have to retrieve the device, to clean it for at least 24 hours. That's what we have been doing, and then deliver to the next.
I mean, one thing that I've realized with regard to clinics is it's very clear to me that I need to have a filter to see whether the patients want to come. 50% of the patients that we've offered appointments for echoes or other investigations don't want to come.
Yeah.
So I now look at the referral letter. My secretary phones the patient to see whether they would come. And then if they would come, then that triggers the investigations.
Yeah.
And then I would do the first outpatient appointment via video or phone. And my feeling is that quite a few of those will not have to come to hospital, actually. Is this your experience?
Yeah, you're absolutely right. If you have at least a general view of what is the key patient symptoms, and if you have already some data, you may simply deal with the patient case with the ECG recordings that can be managed, as you mentioned, by different handful of tools. Whereas if you need diagnostics, that is totally different. And I think you are absolutely right. You have to have a contact with the patient first, and then plan everything in the same session. You see the patient, you do the ECG, you do the echo, all in a single visit. That's what I'm doing with my colleagues in the echo lab. We work together. So once the patient comes, we have a full evaluation, and the patient doesn't need to come again.
Sure. So Professor Pendergast from Oxford then talked to us about valve disease, and clearly we've all been heavily dependent on imaging over the years to an extent where the stethoscope has been relegated to the shelves. Now, this changes things. I think the main message from Professor Pendergast is that we have to be pragmatic. And we have to consider identifying the disease more than ruling out things. In an ideal world, it would be nice to exclude things, but he was very keen to focus on particular risk groups. One of those is in stenotic patients, in aortic stenosis patients. He showed some data in which patients do perish very quickly within 6 months to a year after the onset of symptoms. So after following up patients with aortic stenosis, he showed some data to show that if they developed atrial fibrillation or a new symptom, breathlessness or syncope, that was really something that we should be coping with now, even with the COVID pandemic.
Yeah, we were outlining with him that indeed having a very well conducted patient interrogation by key questions and monitoring of very simple signs, just like the heart rate and the type of rhythm, irregular versus regular, that might suggest AFib, would pick up those patients most likely to have clinical deterioration.
Yeah.
So that again brings up the point of continued remote patient monitoring.
One very nice tip that he gave us is that if you see a patient with aortic stenosis and a temperature is not during the COVID pandemic, you really need to make sure that they don't have infective endocarditis. And he has come across cases like this. And of course, if you are not examining patients because you can't, and you don't have a high level of suspicion, you might write it off as aortic stenosis uncovered rather than infective endocarditis. I thought that was very useful.
Yeah, something you have to remind.
And in terms of surveillance, I mean, he was very keen to rely on the baseline study and then to look at progression either through telephone, also with BMP. And I would agree with him that BMP here, in following up valve patients, is complementary to a telephone consultation. And we may not need to do routine echoes in the valve surveillance clinics. So we then went on to imaging, and Dr. Nick Sabawal from Oxford presented a strategy, and again pragmatism prevailing, because we don't have access to imaging, and in particular TOE is going to be very difficult. I must say that the logistics of COVID and non-COVID pathways in the majority of hospitals in which we only have one cardiac MRI scanner, it's going to be problematic as well. He again underlined the importance of taking a history, and it goes without saying, but it's more important now. The ECG in primary care and increased availability of that. We have found that very difficult, actually, the quality of ECGs in primary care, and we've put in various measures to try and train ECGs, train GPs and their staff on ECGs, but we have found that very difficult indeed. I don't know what your experience is.
Well, that is a common finding everywhere in Europe. If you have to rely on general practice with a 12-lead ECG, that becomes an issue. In my region, we have a very good primary care government that provides home care to patients who have really difficulties in coming to the hospital. And the pandemic highlighted the role of this particular staff. So for those patients where we were in need of 12-lead ECG, they went to patient home and record an ECG for us that was transmitted instantaneously. Yeah. So actually the cardiologist in charge was seeing the ECG in time and giving back feedback, kind of consultation if the patient has symptoms, or if a medication had to be changed, up titrated, down titrated. Yeah. But this is exceptional for those regions where you have a very good primary care force. And this is quite unique in Northern Italy. In our region, it's not common everywhere. Yeah. So to talk about generalization, we should aim at something that relies on probably less than 12-lead ECG, because it's difficult that someone will do it for you. But the patient can learn how to use something just providing 1 or 3 leads. There are tools already available. So as far as either, say, palpitations, lightheadedness, syncope, or sometimes chest pain, that can be useful, because you see dramatic changes.
I agree. I mean, the other population of patients that we spoke about was the cancer patients who now routinely get echoes, 3-monthly echoes. Clearly, this is a focus for attention now. And we talked about BMP in this context. I think that this is a very good pragmatic approach. The incidence of left ventricular dysfunction and the progression of left ventricular dysfunction in these patients is really very, very small numbers, but very important numbers. But I think it's highly unlikely that we are going to miss an important clinical problem if the BMP is completely normal.
That makes the point of having a, let's say, reference line once you enroll the patient into a treatment.
Yeah.
And keeping the steady pace of testing for relevant changes in the therapeutic regimen of that patient. So BNP provides meaningful information. Otherwise, yes, spotty measurement may lead you anyway, but to the diagnostic clue that you are looking for. So that's very important.
In the next talk, Matt Swift from Swindon told us about the organization, the logistical problems that they've had during the COVID pandemic and likely solutions. He threw various figures, actually, which tally with the sort of figures that we get. Yes, remote monitoring is very effective, and in fact, there is no option now, because when we had the opportunity to see patients, then there was the option. And in fact, the literature has always compared remote monitoring to standard of care. Now, the standard of care now is not face-to-face. So basically, there is nothing else but remote monitoring.
Yeah.
One of the issues is cost, of course. The other is the number of alerts. So he gave a figure of nearly 20,000 remote monitoring alerts in 1 year, in 2019 to 2020. And those have to be looked at, acted upon, and sifted. So, I mean, one challenge that we have had is sifting out the false positives. Is this your experience as well?
Yeah, sure. I dare say that everyone who has experience of remote monitoring has the issue of false positives. But for certain alerts, this opens also the way to general medicine, because many times the false positive is a false cardiologic issue, but it's a health issue anyway that focuses on something else.
Yeah.
Lung disease or renal disease or an inflammatory disease. So for us, it's a must to keep your eyes open wide. And for instance, if the alert has several recurrences, probably a web-based communication with the patient just to investigate some symptoms and try to refer the patient to a dedicated specialist other than a cardiological one is worthwhile.
Yeah. So Matt Swift also considered the new heart failure diagnostics. I think we have to be slightly careful because the value of this is questionable, particularly the monoparametric measures, single measures such as Optival. We've the new measures, the multiparametric measures, and all the companies have them, are being tried. But I mean, I would suggest that yes, the evidence is not there for a complete implementation, but nevertheless, it is something else we can use, isn't it?
Yeah, absolutely right. In the past, when we were junior trainees in general medicine or cardiology, we were used to evaluate several signs in physical examination to draw a picture that was heart failure or wasn't heart failure at all. And this multi-parametric thing is just like this. We try to work out a diagnosis by a constellation of signs and symptoms. And this has to be built on device-derived parameters, measurements, and probably if you engage the patient, also some patient evaluation as we were talking formally.
Yeah. In the next talk, Ian Wright told us a similar experience in Imperial College in London. He gave, again, quite interesting figures. So out of 4,000 patients with a device that they have in their books, over 1,800 of them are over 80s. And in the young patients, in the less than 60 years old, the disease burden is very high. So this is important, isn't it? Because those are proportionately at a much higher risk. And perhaps one should focus on those patients first to put on telemonitoring.
Yeah, absolutely right. Disease severity in a young patient must be something different from the octogenarians.
Yeah. I mean, he also provided some very nice data, albeit small numbers, of course, because that's the nature of the game at the moment. But they saw an increase in deaths in ICD recipients, long-term ICD recipients, from 4 a month to 12 a month. Not all of those were COVID. but nevertheless is doubling or trebling the mortality that one would expect for that month. It would be useful to see actually in data sets going forward whether this is really what's been happening.
I would say that probably if we run a multi-center evaluation like this based on the remote monitoring data sets that we have in our centers, we will find out interesting things in the next few months. Just because of what you said, there are patients who are threatened to come and that are shifting to underreporting of symptoms. So how can we pick up relevant changes unless we have objective measurements, as you said, BNP, heart rate? They are quite rough, but they are something valuable.
Yeah. So Trudy Loban talked to us about patients, and clearly there is a great deal of acceptance of remote monitoring amongst patients. Her view was clear that the overwhelming majority of patients, in fact, she quoted the figure of 100%, wanted remote monitoring. As I was very pleased with that. I think actually to give the option of remote monitoring with the option of face-to-face is something that we've been doing for some time, but I think it's much more important now. The advantages for the patients were mainly centered about not having to take a whole day sometimes for an elderly patient to wait for transport to be taken to hospital. They get back in the afternoon or sometimes evening just for a quick check. It's something that we should consider. And the risk, actually, the number of contacts that those patients have during the whole travel to hospital is considerable. So it would be nice to see in some publications really what the acceptance rate from patients are and exactly what their views are. But her impression was pretty much the same as our impression, that there is a great deal of acceptability.
Yeah. I was personally struck by some sentences that she reported coming from patient feedbacks that were I did not feel abandoned,
Yeah.
or I had the feeling of being watched by my doctors all day long.
Yeah.
That means the level of safety that the patient receives is much higher than before.
Yeah. Yes, and in fact, patients were reassured to find that if there was an alarm or a problem, they would get a call from the hospital.
Yeah.
So, well, I mean, I thought that the series of talks that we've had have been very useful. Clearly, this is a change from traditional medicine to a very different type of medicine. We all realize that it is not ideal, and patients also realize that it's not ideal. But we've had a lot of suggestions as to how we might proceed from now on. We think that the horizon for this is going to be 2 years, perhaps. There was emphasis on trying to really rule in disease rather than rule out disease, and to focus on the positive predictive value. We also saw how hospitals clearly are able to get rid of red tape very effectively. That is a lesson for all of us. Yeah. I think in all, we are very grateful to all the speakers who have contributed to this. I'm particularly grateful to you, Mauro, for giving up all your time. I feel very guilty that we've taken so much of your time, but you've given us a great perspective from your experience.
It was definitely a pleasure and an honor to me, but I simply regret that it was scattered through different activities, because now we are simply mixing up the tail of COVID infection and the upsloping of what is the new normality, and it's much more difficult to design a new normality that is coexistent with the virus than to fight your enemy. That's definitely a battlefield, and you know what you have to do. Now it's simply going by trial and errors, even though you can design a so-called safe workflow with some protective measures, but it's not taken for granted that it will work. Now we are simply engaging ourselves into something that is a new challenge, and we'll see what happens. Hopefully, the UK will take, something wiser, so we can exchange information and try something better.
Absolutely. I think we're all getting used to this, but it would be great to have your advice on not just COVID cases, but non-COVID cases in the future. So thank you very much. I'm very grateful to Paul Foley as well, and the BHRS, who have put all of this together. And I wish also to congratulate Radcliffe for being fantastic. They've done a wonderful job. So thank you.
Now, one comment is that this is a first attempt at doing something like this, and we surely learn something to improve in the future, but it was a great experience. Now it's a brilliant idea that you had.
Fantastic. Thank you, and bye-bye.
Bye.